So thank you to everyone for coming this evening and letting me speak with all of you. I'm going last, and I figured going last I would try to do a lot more videos and a little bit less charts because I figured you'd have a lot of talks about what PNET is. I'm going to focus specifically on insulinomas. Before I go forward, no disclosures related to incision. I'm a consultant for multiple companies, none of which is related to this. I'm also the president for our Multi-Specialty Cancer Institute and serve as our director of interventional endoscopy at Parkview Health with adjunct faculty at Indiana University. So a little bit just about pancreatic neuroendocrine tumors and specifically insulinomas. As Dr. Block pointed out, they're quite rare. We know that less than 10% or less of tumors are neuroendocrine tumors involving the pancreas. The rest are predominantly adenocarcinomas. To point out something that we had shown in a poster presentation earlier during DDW this time, we're finding a lot more of these tumors. Many times they're undetected on CT scan, and they're referred to us as advanced interventional endoscopists, oftentimes for other reasons, or they have an elevated lipase, for example, and we find these tumors at an earlier stage. So now that we're seeing these tumors and they're less than 2 centimeters, we're stuck with what to do with them. And another poster that we presented here this week, we found that we're using fine needle biopsy now for all of these tumors. And in doing that, we're actually able to substratify these tumors and get a mitotic index and also do specific biomarker staining. So in our paper, we showed that we were finding tumors 15% of the time they were not detected on a 64-slice CT scan. We review them at our multidisciplinary tumor board, and then it comes across the question, well, what do we do with these neuroendocrine tumors that may not have a lot of function, but as Dr. Block pointed out in his lecture, these could progress potentially. And do these all go for surgery, or can we substratify them based on biomarkers that we couldn't have before? So now we core everything. We don't do any FNA at our center. We do all FNB. So we're able to get large amounts of tissue. We can do all sorts of stains, synaptophysin stains, find out mitotic index. And then from there, can we pick out selected people who might be more eligible or more applicable for less invasive treatments rather than subjecting them, all of them to a Whipple. And I think most importantly, I've selected 2 cases that have occurred in the head of the pancreas. And that's really important because a Whipple surgery is very different than at our center. Almost all of the tail surgeries are done laparoscopically unless they're extensive vascular involvement, which has much lower morbidity. So specifically to these patients, you're going to see 2 cases of functional neuroendocrine tumors, both insulinomas, debilitating to these patients, young patients, a patient who was 36 and a patient in his 40s, and both of which had very low features of high elevated mitotic index. So both of them have a mitotic index of 2% or less, both of which had confirmed biomarkers with a very low susceptibility to progression. Both undergo a multidisciplinary tumor board review, and then we're stuck with the option of Whipple versus doing something less invasive. And in both cases, the oncologists, as well as our surgeon, were progressive enough to discuss the options with their patients, and both of these 2 patients opted to go for EUS-guided RFA ablation. So that's what I'm going to walk you through. So actually, one thing that we do here for our patients in our Multidisciplinary Cancer Institute is we actually use animatage tables. And I like to do this for our patients so they understand what it is that we're offering them. Anytime that you're in the space of interventional endoscopy, and we do hybrid ESD and full thickness and now EUS-guided RFA, and you're pushing the edges of the envelope, you want to make sure that you partner with your patients and you're able to explain to them what it is that you're doing. So this is a pre-procedure video that we actually show our patients. Let's see if I can get this to show here. And it actually is our own patient. So we take CT, we use an animatage table, and we upload our CTs into the animatage table. And you're able to actually see here what this patient's pancreas looks like, the size of the tumor, which is less than 2 centimeters, and we can show them exactly where their insulinoma is related to all the vasculature as well. It's important for them to have a good understanding of what this is. What we really like about this is we then go back at our tumor board after we've done these ablations and show our oncologists, because we've got to try to get buy-in, right, from all the rest of the medical community that this might make sense. And so this allows me to get buy-in from other specialists that may not have ever seen anything like this before or might otherwise think we're a little crazy. So here's what it looks like when we do our EUS-guided RFA. And actually, you saw this video, so I won't walk you through all of this. But if you look at it on an animatage, what it looks like after we do an RFA on a patient, this is the exact same follow-up. And we did a PET CT. And one of the 2 patients has absolutely no uptake on their PET CT. So you can see where their insulinoma was before, and you can see that you can't see it anymore on the CT scan without a lot of extensive damage to the surrounding tissues, which is also important to us, right? Because we have a potential for side effect with this treatment, which we haven't seen. And then what does it look like if there's a Whipple? So all of you know what a Whipple looks like, but it's nice for us to show our patients and talk about, okay, if you opt for a Whipple, what is it that's left over? And sometimes we place a pancreatic stent in the time of the Whipple surgery, but you can imagine that there's a limited amount of remaining pancreas. They are at downstream risk. So for all of us who are interventional endoscopists that work out of cancer institutes, we follow these patients. So I have a number of patients in their 30s who are now in their 50s who had Whipple's before, who we're trying to help manage afterwards, and they can get jejunal pancreatic duct and anastomotic strictures. They might not be ever functional or normal again, and so we have to think about these things in consequence for tumors that might not have a lot of progression if we have a very elegant, optimal solution. So I'm going to show you patient number 1. So we're still trying to figure out the dosimetry for these patients, and I know that was pointed out really nicely by Dr. Tosani. So for this first patient, you'll find the dosimetry is a little bit different. This patient actually got intubated for her first session and had got 8 ablations. The wattage is the same as everyone else. The individual ablation time, we pushed the envelope a little bit with 2 minutes, and they got a 1 minute of rest time. We did follow impedance for this, so we actually have a subsequent follow-up paper where we're looking at how impedance levels and do they correlate with what we find long-term. And when I say long-term, how do we follow these patients? We're choosing to follow them all with PET-CT because that seems to be very popular in the literature with the medical oncologists. There's a cost associated with that, but I think as we try to get people to convince to follow this, PET-CT is being followed by many of the medical oncologists. We're actually looking to present this at ASCO, which is their big conference coming up in June. And for them, they want to see a PET-CT that's negative. If for some reason that's very important to them. For us, what we care about for these patients, or what the patient cares about, is what's happening to their hemoglobin A1C, what's happening to the resting glucose levels, are they getting dropout? In other words, both of these patients showed up to our ER, one of which is already being managed by our endocrinologist, and they were blacking out. And they were completely acting abnormal, and their glucose levels were dangerously low in their 30s, which is how they presented. One of the 2 patients actually was not able to be found on CT scans. We actually did an EUS looking for an insulinoma, and as those of you know who do a lot of high-volume EUS, oftentimes that doesn't have a lot of yield, but in some cases you get lucky and you find something. And this is a video of what this looks like, and I won't go through the entire video. It's quite a long video, but I will point out that we actually are using an Aloka 10. It's a little bit older of equipment, so it might not be as clean as some of the other videos, but even here you can see what the tumor looks like in the head of the pancreas. So we're combing through the head of the pancreas. You'll see it pop up. And then in addition, you'll get an idea of what it looks like when you drive. A 19-gauge needle is what we used, and then what the probe looks like after you put it through the 19-gauge needle. And so here you're seeing us map out the portal vein, and then you'll see where the tumor pops up as well. And so here, the black area, for those who don't do a lot of EUS, that's your tumor. Both of these tumors are less than 2 centimeters. Our other video is quite shorter, but I think what's nice about this is you'll get an idea of how well you can visualize both the probe as well as your flexible needle, and then trying to get them to mirror up. And again, to echo what Dr. Tosani said, when we went back and did subsequent ablations, you have less idea of what's left over viable tissue. And if you noted my measurements don't change actually on some of them because they look a lot like Dr. Block showed. There's a big black area and there might not be viable tumor left. So sometimes some of the probe is still left inside your EUS needle. It would be nice to go back and look at the needles. On observation, we didn't see any damage to the needle. We didn't see any problems with these patients, but the probe might not be all the way out. I'm going to fast forward the video a little bit so you can get an idea of where the probe is. So here you're seeing your probe tip, and it shows up as a white mark here, and then back here is where you're seeing the needle. So you've actually advanced the probe. You then would retract the needle, and so the top of the needle is at the proximal part of the tumor, which we do anyway when we fan, right? We bring it back to the proximal part of the tumor furthest away from the deep portion, and then we start our ablations, and we do a series of ablations, and as was pointed out before, you can see some tumor effect right away. What's nice about both of these cases is after the first treatment, both patients had no more dropout, meaning they had normal glucose levels, or at least glucose levels that were not low enough to where they were presenting back to the emergency room and had no further symptoms. So I'll walk a little bit through the later video. But here's patient number 2. So after we found the first patient did really, really well, and they can actually, this is all done as outpatient procedures. For our second patient, and both of these have 4 to 6 month follow-up now, we actually increased the amount of tumor treatment. So we actually went all the way up to about 11 treatments at one point in time. Again, we didn't see a lot of change in tumor size, and I'll show you what our follow-up looks like afterwards. So this patient's in his 50s and again has a functional insulinoma. So you're going to see your needle get advanced into our tumor here. And we use the same fanning technique that was described before. So we really try to go at 3 different axes towards the tumor in every single session. So all of them got 3 sessions, 3 different axes or angles in which we try to approach the tumor. We are a little bit cautious when we withdraw that we've completely had the 1 minute of rest, because you could get a little bit of effect that you'll see on the duodenal wall. It has no consequence to the patients. They don't get any symptoms from that, but it is something that we're cognizant of when we withdraw. And then again, you can see back and forth, and you should see a little bit of bubbling as well as we treat the proximal aspect. A little better idea of what that looks like. So the probe down here, the needle tip up above, and you can start to see some bubbling effect down below. So what does it look like for our 2 patients afterwards? So both patients had their symptoms completely alleviated from EUS RFA. Both of them have stable glucoses. Both of them, one has a 6-month follow-up and one has a 4-month follow-up. Their hemoglobin A1Cs for both of them, which is important to the endocrinologist, below 5 but above 4. None of them are getting, we actually have glucose logs for a more detailed study, but none of them are having extremely low glucoses, and most of their glucoses, the resting glucoses, aren't extremely high either, which is quite important to them. And then what happens on these PET CTs? So we have PET CTs at 3 months and at 6 months. So for one of them shows no activity at all, and you can't see anything at all in the PET CT, which is nice to show at tumor board at 6 months. And for the other one, there's actually a slight amount of activity still left. What does that mean? We're not quite sure. So she's going to actually get a follow-up EUS. We're trying to limit the number of follow-up EUS, again, for cost efficacy and trying to figure out what the total cost of this is. We also have someone here at our main campus at Indiana University is doing a cost analysis on this against Whipple. And what does it total look like in the cost analysis? And already the prelim results look quite favorable for us. So for our conclusion, obviously decreased morbidity and mortality, probably an overall cost, and we'll have that exact cost mapped out here over the next month or 2. It's less invasive. And then future potential. I think a big question for us will be what that dosimetry looks like and what are the 1- and 2-year outcomes from this. And a future study for us that we'd like to look at, we use confocal laser endomicroscopy for our pancreatic cysts that are over 1.5 centimeters, and we've started to determine that we're finding more low and high-grade dysplasia. We know that not every cyst that's over 3 centimeters needs to go for surgery, so we'd like to substratify some of those and look at RFA potentially for those who have high-grade dysplasia or low-grade dysplasia for cysts.